think it's what truly success looks like. And historically, that would be coming back to the base and saying, oh, we had this challenging airway and I got it in on the first crack. And everybody thinks that there's this person who's a hero when you're really doing something to somebody. And glorifying that as opposed to doing something for somebody.
I had a great mentor who was a paramedic instructor, Mark Yeager, years and years ago, and he said to every incoming paramedic class, congratulations, you have chosen to be a servant. Being a servant means you put the needs of your patients above your own.
What does it really take to deliver truly patient-centered care in EMS? This is the EMS Clinical Brief, where we explore how research, clinical expertise, and patient values guide care, and how quality improvement and culture can shape what's possible. Welcome, everyone, to the inaugural episode of the EMS Clinical Brief, which is a podcast we have started in Rochester. And the background to this episode, which I want to give because this is the very first episode, is our goal is to put out continuing education on things that are clinical and quality initiatives that we have in our region. And we think it might be important in Rochester. It's usually important somewhere else as well. And that is one of the reasons that our goal for this podcast is to have not just local folks, EMS physicians through our Office of Division of Pre-Hospital Medicine at University of Rochester and field clinicians from our area, but also have external experts in the things that we have been, the subjects that we're going to cover on this podcast come and weigh in on what we're doing. Because I'm going to be perfectly honest, every good idea we've had in our region came from somebody else. I think if we have one area of expertise as EMS physicians, it's ripping off and duplicating the work of other experts. And I think that's actually the process by which EMS moves forward. And so our first episode is going to be on a topic that I think lots of people like to talk about, which is airway. And it's really about patient-centered airway management. And the reason that this is the first episode is that many who've worked in our region and those who have participated in national initiatives know about the NEMSQA Airway Collaborative, which I think was this really remarkable initiative where more than 50 agencies across the country came together and said, how can we do better? Like, how do we honestly measure our performance around airway management? And then how do we commit to doing better over time and share our ideas so that everybody can grow? And our region participated in this. And as a result of our region participating in this, where we focus particularly on drug-assisted airway management and airway safety, so confirmation invasive airways, we learned a lot about our region. And part of that is we passed some clinical policies in our region. And I don't believe that we should just pass clinical policies and say, like, do what I say. I think we need to explain the why and the evidence because in general, like, I don't change my practice just because somebody says do it that way. I change my practice when somebody says, this is what the best evidence says that you should be doing. And even if I very often can have a little bit of resistance, mostly because it makes you feel uncomfortable to realize that we may have been doing things wrong for a little while. When new evidence emerges, you gotta change what you do. And I think airway management is something where we've changed a lot of the philosophy and what we're doing. So I'm going to have our guests introduce themselves. Shane, I'm going to actually have you go first. Can you tell those who do not know who you are a little bit about you?
Sure. I'm Shane O'Donnell from upstate New York. I practice in the Melrose region, the deputy chief at CHS. And I've been a paramedic for some time up here and done some flight medicine, some critical care transport.
And was integral to all the quality initiatives we did around airway management. And our other guest, I think, really needs no introduction to most. But the reason I have him here is that I think there are a few people, like sometimes you like say a word and you say a name, like I think if somebody says lift assist, like that's when my name gets mentioned, like old people, Maya. But if you say EMS Airway, his name I think is one of the top of the list that comes up, and that's Jeff Jarvis. And I think Jeff and I like to debate a lot, but I think that the fundamental truth is I think while sometimes we have disagreements about how do we get to particular destinations, I think Jeff and I share a lot about like what is the correct destination. And I think we both believe deeply in patient-centered airway management. And we're going to talk in this podcast about what do we even mean by patient-centered airway management? And maybe we'll have a little debate. I think probably a fair amount of agreement to explore this. But Jeff, do you want to introduce yourself and say a little bit about why you let me pull you onto this podcast?
You bet, Maya. So, my name's Jeff Jarvis. I'm a paramedic, an ER doc, and an EMS physician, and I have the honor and privilege of being the medical director, chief medical officer for the Fort Worth Fire Department and our regional EMS system here. Also, the host of the EMS Lighthouse podcast, where I talk about translating science into practice, which is really what my passion is. I love the framework that you laid there about our disagreements. It's not about the destination, it's the route. Now, as I'm sure nobody who knows Maya would be shocked, she gets the right destination all the time. But let's face it, y'all, I'm a man. I do not ask for directions. It's part of our DNA. We're eventually going to take lots of wrong turns, but get to the right direction. MFD here can just get right to the right direction. Frequently, I learn a lot by listening to how she disagrees with my route choice. And it is not uncommon for me to correct my route because she has told me I'm going the wrong damn way. So thank you, Maya.
I think it's mutual. I think we are all eventually getting to the right destination together. And I think around airway management, there's been a lot of wrong turns in EMS. And I think one of the things we're going to do today is kind of explore what those wrong turns are, because you got to recognize that certain things that are the way that we've always done things or where we've put value, as we've had greater ability to get data about what does good look like and in terms of what matters to patients. I think we've learned like, we've probably been hurting people.
I personally have definitely been hurting people, both in my EMS or my ER practice and my EMS practice. I
Yep.
know I can think of at least 3 very large wrong turns that I made that were made for all the best intentions. But as Mike Tagman would say, dude, think about the balancing measures. You squeeze here, what happens over here, and you need to stay focused on what matters to the patient. So it's been a journey of improvement almost.
So I'm going to actually start that because I think we throw around this term, right? I put out there patient-centered airway management. And I'd like to hear from really both of you. When I say patient-centered airway management, what does that mean to you?
I think it's what truly success looks like. And historically, that would be coming back to the base and saying, oh, we had this challenging airway and I got it in on the first crack. And everybody thinks that there's this person who's a hero when you're really doing something to somebody. And glorifying that as opposed to doing something for somebody. So success might say, I had this patient who was a really challenging patient, but I was able to improve their oxygenation and ventilation and hemodynamics. So over the next 10 minutes, we drastically improved this person's course. And while I didn't put the airway in, I really optimized that to happen 10 minutes down the road, as opposed to I put a tube in the hole, their sat hit 50%. We had a brief arrest, but we got them back. But I did get the tube in.
Plus or minus the brief part of the arrest there. I promise you, the patients I have put into arrest from peri-intubation hypoxemia, I promise you my perception of how long they were in arrest is dramatically different than what the monitor will tell me. Humans just aren't able to tell time very well under those circumstances. So I like your framework and I like the way you said that. Even though as a paramedic, what I heard is you're trying to take my laryngoscope away from me. And I will tell you, you'll get my laryngoscope when you pry it out of my cold, dead fingers because it's about me and it's about my ego. And that has been, this has been ingrained in my head, and I'm owning this as part of how I identified as a paramedic since graduating in 1988. I've been a paramedic for 30, good God, however many years that is. And that is just part of our culture. That's how we defined ourselves, as he who intubates or she who intubates. not he who manages the airway and deals with what the ultimate outcome is. So for me, what a patient-centered outcome is, I go back to one of the guys, I've never met him, but I learned a lot from him, Dr. Jerry Hoffman. He is sort of notorious in emergency medicine about translating science into bedside practice. As a matter of fact, I was deeply inspired by him to create my podcast, and he talks about DOEs and POEs. So DOEs, DOEs, are the things that we love to measure in EMS. Those are the disease-oriented outcomes. Those are the process measures. The reason we like to measure them is because the light is really bright on those. It's easy to measure. The data is relative, that there's a lot of data on it, and it is something that we feel good about. POEs, on the other hand, are the patient-oriented outcomes. That is the thing that the patients care about. So the patient, as much as it pains my soul, doesn't care whether we get the tube in on the first try. They care whether they leave the hospital neurologically intact or not. That's what they care about. And it is this journey of improvement that I've been on for the past 30 years to try to move from the things that I care about because of my ego to the things that the patient cares about. Slowly but surely, and maybe this is part of getting older, maybe I have lived long enough to inject a little bit of maturity and to recognize that it's not really about me, it's about our patients, and we should ask what they care about. So that's what it means to me, Maya.
I love that you bring up Jerry Hoffman. Very early in my career in emergency medicine, I actually had an opportunity to collaborate with Jerry Hoffman around we did a Delphi analysis called the Right Care Top 10, which was on thinking about examples of not just it was about overuse and underuse. Like, what are the top 10 things that are overused in emergency medicine, as well as the top 10 things that are underused in emergency medicine? Because we do have a lot of things that are overdiagnosed or overtreated, and a lot of things that are, I think, far less sexy or underdone than thinking about, safe discharge plans for people and things like that.
Can I take two guesses, one for the top, one for the least?
Sure, I'd have to look back on the paper, but I think I can remember.
I'm going to go with either a D-dimer or a troponin for the most
that was one and
overused.
two. That was 1 and 2 for overuse.
Awesome. CT was probably right under there. And then
Yep,
for least used, I'm going to throw on, and UDS I'll put on the overused. Let me put a TSH on the underused.
TSH and UDS never made the list. And actually, like 5 of the underused were all kind of thinking about patient-centric factors, like things about having goals of care conversations in the emergency department were underused interventions, because I think we often think about, in emergency medicine, very much like EMS, we think about the things that we can do rather than putting things in terms of like, what does this patient need most in the circumstance. So I hadn't thought time about this paper we published, like 6 or 7 years ago.
That's awesome.
But Jerry Hoffman was somebody who also inspired me to think about, the why. And to nowadays, like anytime a resident says, I'm going to order basic labs, I'm like, what's basic about labs? There's a question that you're trying to answer. And I think
that's always a really popular question with your residents, isn't it?
Yes, that's
So they
love you.
But it made you, the part of it is you should always be thinking, when I'm doing something, when I'm doing either a test or I'm doing an intervention, I should be able to justify that in terms of something that doesn't matter to me. Like, it is my curiosity that I know the answer to this, but something that matters to the patient, like it's going to change how I manage this patient. Or
why are you transporting that patient in cardiac arrest? Well, it will make me feel better.
The other thing that, now that you brought up Jerry Hoffman, I'm going down things, is Jerry Hoffman also taught me not to talk about risks and benefits, but harms and benefits. Yeah. Because when you say risk and benefit, it's like there's a risk of harm. It's not totally real, but there's a risk of a harm, but there's a definite benefit. The benefit exists. And he says the opposite of a benefit is not the risk of a harm. It is the harm.
Yeah.
And so you should be weighing harms and benefits. And I think that is completely appropriate to this discussion of airway management. When that things go wrong, they really go wrong. And the potential for harms are really great. And so at every step of the way, when you're thinking about what are the potential harms of one intervention versus another, nothing, and we get into this area of clinical judgment where we're trying to make difficult decisions in high pressure situations, in patients who are truly in extremis, and being able to navigate that and say, to the best of my ability, what do I think is really going to benefit this patient most? Not what is going to make me feel like I get to exercise my skills as a paramedic or a physician the most. To me, that is like the crux of patient-centered management, is that my guiding question for everything I do is, what does this patient need most in terms of outcomes that matter to them? Neurologically intact survival, right? Like lack of adverse events, like things that matter to the patient. And I think if we kind of look at the past, and like move forward, I think we have a lot of room to celebrate that and to teach people, to feel just as good about the person, actually feel better about the person that was never needed to be intubated because they were managed very well non-invasively and turned around, than they feel about the person they successfully like intubated in that circumstance. Because focusing on physiology is greater complex decision making and technique than putting a tube through a hole and saying that you did it.
I think physiology trumps anatomy so many times. Absolutely. Anatomy is just the path to get to physiology.
So I have a kind of a general question of like, how do you know, right? Like, because we're talking about kind of an individual patient interaction, saying this is what patient-centered airway management is. But I think patient-centered airway management is fundamentally a characteristic of EMS systems, right? That are on the spectrum of like, they're very focused on procedure-based management versus like a lot of focus on kind of this patient-centered management, like EMS systems and agencies. So how would you know, if you're taking the I don't know, the pulse or the pulse ox, since we're talking about airway, or the capno, right, of your EMS system or your agency, and saying, do we think that we're more procedure centered or more patient centered, when it comes to airway management, like when you look around? Because I think it's kind of like everything's on a spectrum, right? Like I don't think there's a single EMS system where 100% of the interactions are patient centered. I'd like to achieve that someday. But how would you know? Like, what would you look at?
I think one easy way to do this, knowing that I'm about to suggest a metric that we're going to fail in my system, is take a look at what a system measures and what they work on improving. So if you are measuring 100% procedural process-oriented measures and you're not measuring the patient-oriented outcomes or the patient experience, then you are probably not a patient-centered EMS organization. Now, having said that, I recognize that, boy, I just hung a large rope around my neck because with a couple of exceptions, we're not very good at that. We can do a lot better. But if you are an organization that looks at process measures only, what are you proud of? Are you proud of your patient satisfaction scores? Are you proud of your cardiac arrest survival rate? And you are measuring that in terms of neurologically intact survival. Are you proud of all of the letters you get from the little old ladies who fell and couldn't get up and you just held their hand? That was for you, Maya. Or are you really proud of your intubation first pass success rate, your IV success rate, how well you can splint a femur fracture, or to put that in realistic terms, how many of your people actually know where the traction splint is? If those types of things are the process outcomes you value, or measure, that's probably what your system values.
Part of it too can be done by listening to what people say around the kitchen table or in the ambulance to their partners and how they describe their interactions with patients. If your crews are coming back and saying, oh, we started an IV on this really difficult patient and I was successful in doing that, and that was the gratification that they got, I think that's a lot different than I went for a person who fell and broke their hip, and I was able to provide them really good analgesia, and they were able to be super comfortable while we carried them down some bumpy stairs and went down the bumpy road. And I think both those seem procedural, but one benefits the patient a lot more than the provider itself.
Let's talk about airway management, because there are metrics for airway management. Jeff has had
Really? I
a
didn't know that.
strong role in developing those. And so I think thinking about the family measure, there are things that we have national measures for, and some that are kind of like I would say partially developed national measures. They like weren't adopted nationally, but were part of the evidence-based guidelines project that Jeff led, came out of that, some of these measures. Tell me, name a measure and tell me what aspects of it are patient-centered and what are procedure-centered? And like, what would you combine it with?
So I think there are a bunch of different ways to look at performance measures. So one performance measure is of patients who received an invasive airway, what is your survival rate? Now, one of the reasons that you've probably never heard of that measure is it is unbelievably complicated and challenging and confounded. Massive confounding, because first off, we don't put invasive airways in patients who are likely to survive to begin with. So your survival is probably going to be low. And the skill with which you carry out that procedure impacts the survival, but also the base state does. So lots of confounding, and that's the reason you don't see that. There are more straightforward procedural success measures, overall success in your invasive airway. That is one. It doesn't matter how many times you try, as long as you showed up at the hospital with an airway intact. Just to be clear, that was used with my sarcasm voice. That would be one.
He was not saying that's a good idea.
Like, who's this
And then
expert?
there are exactly. There are what I would consider, and first pass success is important. I absolutely think it is important. I'll be more than happy to inundate your email box with all of the literature suggesting adverse events go up, mortality drops, or mortality goes up, survival drops when you don't get it. But it's just not enough. And the way I say this is first pass success is necessary, but it's not sufficient. So then you can look at composite measures. Dash 1A or Airway 01 in NIMSCO speak is the classic example of this. It is looking at the intubation, and we're more than happy to explain why this is an intubation-only measure and not a supraglottic measure. But it is intubation first-pass success without peri-intubation hypoxemia or hypotension, measured, I will admit, a little arbitrarily, 3 minutes before the procedure, and that's not terribly arbitrary, to 5 minutes after, which is terribly arbitrary. That is much more correlated with avoiding the things that we know are bad for patients. So we know that missing the tube on the first attempt, bad for patients, adverse events go up. We know hypoxemia is bad, particularly at higher doses, meaning lower SpO2s for longer periods of time. And we know the same thing is true for hypotension. Particularly, it's probably best demonstrated in patients with neurologic injuries, so TBIs. Dan Spate did a great job of quantifying the risk of that in TBIs. No reason to think that doesn't exist in other neurologic emergencies like stroke, and it probably is the exact same thing in all patients. I think we should probably not try to allow hypoxemia in any of our patients. So that is it's a composite measure. It is way harder to hit, but it's much more likely to be measuring something that patients care about. Other straightforward measures, and these are the NIMSCO measures, that's Airway 01 that I just talked about, the first pass without hypoxemia or hypotension. There's Airway 05, which is the proportion of patients who were adequately pre-oxygenated before you attempted. And then there is Airway 18, which is the proportion of patients with an invasive airway that had waveform end-tidal CO2 confirmation and monitorings. Those are a couple of examples of, I think, pretty good measures that we should be looking at that all roll into one composite measure that patients are likely to care about.
And so when I think about those, and we track those, and lots of our work in the Airway Collaborative, and we learned a lot about our system by the process by which we improve that. And I think we improved our culture around safety, right? Like the implementation of checklists and changing kind of the hubris of I know best to saying like, I'm going to be cognitively overwhelmed in this circumstance. And I'm going to say like, I'm going to do best by the patient by using resources that help me do it safely. But I think one of the issues with these airway measures is that they focus so much on intubation and drug-assisted airway management, which is such a minor component of when I think about system design. And so if I think about some of these measures, like one of the things that we track, and we have a regional credentialing program for drug-assisted airway management. And I look at all those, but I also look what percentage of the time are we actually intubating the patient? It's been consistently 27% of those requests get intubated, which tells me we're probably actually doing something right, because patients were making a clinical decision to put in an invasive airway and managing the patients. And I look at that and I say like, yeah, I probably wouldn't have intubated that patient in the field, or that patient was still too hypoxic and they were working on actually delivering a patient with a reasonable blood pressure and reversed hypoxia. But there's also Airway 24, which was one of your measures that came out of the evidence-based guidelines project, was essentially improvement in oxygen saturation. And there is a lot of dirty data around pulse oxes. I think that was something I learned through the Airway Collaborative as well. But it's asking the fundamental question of, it is patient-centered, because it's like, is the last oxygen saturation better than the first? And how much better? And so when I like think about how to look at this in our system, even if some of it actually requires manual review to kind of like see the quality of the data, I think there's a lot to learn about the system. One of Shane was doing work at his own agency on time to capnography use. Right? I think that is an excellent, that's a process measure. It's less patient oriented, but when very often people think about capnography in association with invasive airways as a safety measure. But I think it's also a safe. Vithalani did a whole bunch of work that showed what we knew once he said it, which is we suck at bag mask ventilation. Like, that's not how he said it, but he tried to prove like we systematically suck at bag mask ventilation. But are we actually acknowledging that we suck at bag mask ventilation and we need real-time feedback to improve our skills? Like, do I have a square capnography waveform or not? Am I actually effectively ventilating this patient, or am I just going to like assume because it's a bag valve mask and I'm being successful because I'm thinking, am I being successful because I'm pushing on it, or am I being successful in terms of being able to demonstrate that I'm actually ventilating this patient when they need to be? Because I think so many of these measures focus on the tool to manage the airway. And what the patient cares about is that they are oxygenated and they are ventilated. And that is true. Like we'll talk a little bit about this, about, you know, your review of the evidence when you did the airway, the evidence-based guidelines around airway management, which was really interesting to me, like how much work has been done and how little we still know about how to manage. And I think it speaks to the variability within EMS systems and skills. But like the two truths I know is that patients care whether or not they're oxygenated and whether or not they're ventilated. And that no matter what the pathology, whether or not it's cardiac arrest or trauma or stroke or some other type of respiratory failure, like everything we should be doing should be saying, how do I meet those needs in the best way possible? And understanding like, what is your skill with different tools? And when are you going to use what tool when to make sure that's met?
Couple of things. One, I just got to put a plug out for Dr. Vithalani. So Veer was the medical director in Fort Worth before I came here. One of the things that he directly challenged, and this is a great paper, was our assumption, and I think if we're being honest, all of us would say this, is that supraglottic airways are essentially foolproof. We don't need to use waveform capnography because they're so good. What he published was a 14% failed airway with a King LT. So of all the patients who had King LTs, they were attaching waveform capnography because Veer would yell at them if they didn't. But they weren't doing anything with the information. They weren't looking but it's still being recorded 14% of the time.
I thought
It
it
was
was
a,
Idell in it work, or he did
No,
both.
no, I was the one that slayed the King LT here. So that was, now he's done some other work with iGels, but the failed airway was with the King LT. The issue of don't focus on intubation, focus on improvement in SpO2 or ventilatory status. I think that is, I think it's a bit of a red herring because I think you need to look at all of them. The key thing is not to confuse what you're measuring. And when you try to lump a lot of things into one measure, you end up incentivizing bad behavior or making good behavior look worse. So, as an example, Airway 01, if we include supraglottic airways, you're overlooking the clinical decision of when you use the supraglottic and when you intubate. So if you are doing what I think is appropriate intubation and selection, which is the only time you're intubating, is when you have proven it is safe to do so. In other words, you have optimized the physiology to the point where you think the patient has the best chances of doing well with this procedure. Well, there are going to be patients you can't optimize the physiology on, and those are the ones who are most likely to be hurt if you intubate. So you make the appropriate clinical decision and put a supraglottic in instead. But because they're the ones most likely to be hurt, now you lose the signal because of all of the noise, because you're using the wrong measure for the wrong procedure. The other thing I think you should look at, did you improve the patient's ventilatory status? Did you improve the hypoxemia? But I think those are separate measures and you need to keep them separate so you don't lose the signal and all the noise.
And
Because
right,
I always joke that I don't have any tattoos, but whenever I get one, it's going to say all data is dirty data. The SpO2 data, as you very well know, it is shit data. Very often, if you're just doing a data dump from your EPCR or from your monitor into your EPCR, it's not like anybody's manually entering pulse oximetries. You get an awful lot of
when they
stretcher
do, they actually
SpO2.
enter the respiratory rate as the respiratory rate of 18 as the SpO2, which was one of the when I did manual review. That
Yeah,
also happened.
right.
I was like, the
I
sound
think
was
that might be regional because when we do it, we pick 16. I think we can
Colder
all
here.
agree that the blood pressure is 120/80.
yes.
Every time.
But yeah, I think
So
it takes
you have
it
to,
takes a family of measures. Yeah.
it absolutely, yes, you need your balanced scorecard concept. But the SpO2 thing, the respiratory, it's an important measure. The problem is we found with NIMSCO, as you very clearly pointed out, we can't get there using EPCR data. You can't, I don't think you can get there on Dash 1A using purely EPCR data. I think if you care about this, you have to do, it's labor intensive, and I get that not all agencies can do this, but you have to manually review the waveforms. Uh, and then you can tell, you look at the Zoll file, you look at the physio file, you know immediately whether that SpO2 of 40 is real or not. It makes sense. You cannot physically go from 100 to 40 back to 100. That's an outlier. The thing fell off. You exclude that and you don't look at it. The computer has no clue how to do that. So there are some measures you just have to do manually right now. Maybe, AI will help us here, but it hadn't yet.
Yeah. I completely agree on that. So I had, what do we think? So we talked about kind of the shift from like procedure oriented care to patient centered care. What do you think are the emotional drivers? Because I think we have to acknowledge where they come from, like the emotional drivers of saying, don't you take my laryngoscope? And there's certain things where I'm like, even as a medical director, we'll talk about clinical conditions. I look at the data on cardiac arrest and I feel like I know what I should say as a medical director, encourage people to do. But if I tried to do that, I'd upset a lot of people. And so it's just not it's not the fight that I'm going to have, right? Like I think the data is pretty good that SGAs in places with a certain procedural skill around intubation are the way to go. And I think
So,
my own system, general procedural skill around intubation probably matches a procedural skill around intubation that SGA would be a way to go. But I feel kind of difficult, right? Like I'll acknowledge, like I have a lot of difficulty. Like if I'm showing up and seeing, I'm actually just dropping an SGA and like moving on to the things that actually matter as long as it's working for the job. But I feel differently about taking that opportunity away from a paramedic, though that's not very patient-centered of me as a medical director, and I acknowledge that. It's interesting your thoughts about like where do you think those emotions come from? Because there's an emotional component to it.
I've already expressed my fear about taking the laryngoscope out of my cold dead fingers. I'm interested in Shane's thoughts. But then I want to address the dilemma that's keeping you up at night, because I have it too. It's about picking which hill you want to die on. Shane, what are your thoughts here?
I think part of it's misinformation to say that, I mean, an endotracheal tube has always been, uh, in the past has been stated that this is the best airway for the patient. So then anybody coming in and saying, I'm going to take this skill set away from you, you're either calling me inadequate at my skill set or saying that you're interested in harming the patient, because that is the best thing for the patient. So I think you have to say, and keep turning it back to what is best for that patient. And in many cases, it might be that supraglottic airway based off the literature that we know at this point. Um, and I think it's a huge mindset change for the paramedic, because as you mentioned, Jeff, it's been something that has been associated with the paramedic profession for so long up to this point. But there is that emotion behind that you are taking a skill set away that is important to me, and that could potentially cause patient harm. When in reality, we know it probably won't cause patient harm. It'll likely cause patient improvement.
Here's the thing that I've become more aware of as I have chosen this hill. This is the hill that I'm planting my flag on and that I'm going to die on. If we're going to intubate, we're going to intubate right. If we can't intubate right, we're not going to intubate at all. This is the hill that I'm going to die on. And the reason that I picked this hill is because at the bottom of this hill are a lot of patients that I have personally killed by focusing on this. And it is a mindset change where I realize it's not about me. And again, maybe this is just, I'm 58 years old. I promise you, 32-year-old Jeff, and definitely when I became a paramedic at 20, I didn't feel this way. But it's not about us. It's about our patients. And the reason I'm willing to die on this hill, or how I've demonstrated it, is I came into Fort Worth, and I truly am probably the biggest advocate for EMS intubation, but you got to do it right. And I looked at our data, and our data said our first pass success rate overall, and of course 85% of the intubations were cardiac arrest, was, I believe it was like 45%. I mean, I don't know any way to say that other
And that's
than we
because
sucked.
you're honest, right? Like, and to
Well, and
give
I
us,
looked.
yes, and you looked.
Yeah.
So to give reference to the numbers, because somebody see that number and say, oh, okay. And now that we have video recording intubation, I think anybody who's measuring their first pass success rate by what is documented in a chart rather than by looking at a recorded video is underestimating their success rate. Because nobody and it's not all malintent. I think people are like, oh, I took it out. I don't know, like they may
Absolutely.
not even realize that it's not even part of the memory,
Yeah.
right? Like, I don't think that people are lying on their chart. I don't think it's malicious.
Clearly.
And sometimes if you actually look at the data, there's a narrative about a missed intubation and then a documented successful procedure. So when I tried to look at this across our region using system data and then did chart dives, I was like, this number has little bearing in reality and is a complete overestimation of our performance when I just look by what's documented in a chart.
So it's interesting, because if you take our data, look at our pull image trend data, and look at the intubation first pass success or supraglottic first pass success, and then as the medic documented it and what our objective waveform CO2 we go into the monitor, it is really, really, really close. And it is really, really close because of the work that Veer did on just pounding it into what is the definition of success. And it's not what breath sounds you heard. I don't care what you heard. I listen too. Let's just be honest. We don't know what the hell we're hearing. And it's not misting in the tube. It's not any of the other crap. It is waveform capnography. Is it greater than 5 with a 4-phase waveform for at least the first 5 breaths?
And doesn't disappear.
If it's not, for confirmation as opposed to monitoring.
The initial,
Um,
yes.
That's the definition of success. So that got much better. The thing that gets you on the, well, we actually took 2 attempts rather than 1, NMSIS is not helping us here. The way that NMSIS has structured this data set allows you to record the number of attempts and the number of successes in the same line. And that ain't helping things. Fortunately, most EPCR vendors have engineered around that. It's a real challenge. But to your point, absolutely, you have to be monitoring this data. Go in, look at the VL, and clearly have a standard definition. If you were to ask the medics I would hope that I would get the right answer. What is a first pass success? They would say it is defined as an attempt in which the tube goes through the cords with 4-phase waveform for at least 5 breaths, greater than 5 millimeters of mercury. On the attempt, the time between the blade passing the alveolar ridge or in our edentulous patients, or the teeth, and coming back out. So you come out once, you slip, you trip, for God only knows why you're intubating upside down on, roller skates, but you slip and it came out. That is an attempt. I don't care about your intent. That is an attempt. And you just really have to work on making sure everybody knows that. Going back to the die on this hill, there are some things that irk me that I really want us to improve on, but I'm not willing to die on that hill. So maybe I want to modify it a little bit. If I had my way, the only time an MCD would go on a patient is if we have to transport them. I recognize that I'm going to have to die on that hill. So instead, I said, you know what I'm going to do? I'm going to plant a bunch of flags around the halfway up the hill and say, don't put it on in the first 15 minutes. I came up with a compromise. Cardiac arrest, on the other hand, our Utstein survival rate was lower than the national average, and our first pass was lower. I just said, thou shalt not intubate cardiac arrest. Your first attempt will be with a supraglottic airway. Done. There's no wiggle room. This is not a clinical decision. Use a damn supraglottic. Now, if that fails, yes, you can intubate, but put a supraglottic in because we have demonstrated benefit in this system looking at our data. Same thing with hypoxic intubations. I just said, look, number one, stop intubating without a paralytic. This is the way we will intubate. We will always do it this way. And if you can't get the SpO2 above 93%, so 94 or higher for at least 3 minutes, and have a blood pressure above 100, don't intubate, period, ever. Use the supraglottic. And the reason I'm so black and white about that is, one, all the bodies that I have personally stacked up down here by doing something different, and it matters to patients. And I've seen that, you know what? Once I say I'm willing to die on this hill, go through exhaustive explanations for why and what the literature is, and demonstrate the bodies, we get over it pretty quickly, and we become converts to you know what? We actually were harming.
Yep.
Other things, not so much.
That's a really nice tie into thinking about how do we balance system policy with the unpredictability of EMS and preserving clinical judgment. Because I think every time we pass a policy, there's always the patient who's the exception to that rule, who's brought up like, but in this circumstance happens, like, what am I going to do? And actually, we'll talk about some of our clinical policies that were passed as a result of this. But Shane had a patient that didn't pass the clinical policy, and there was all this verklempt about the tube being removed. And I was like, well, that patient's going to be as dead as they were before with or without the tube, but at least they didn't die, right? Like as a system policy, you have to say like these are the lines on the sand, but there's some things that allow for clinical judgment. And I think that's where I struggle, because I have to kind of make decisions and create processes that don't have slippery slopes that justify bad behaviors. And when I'm not thinking about like the one time at band camp when somebody had this weird thing or that one case. I have to think about like normal operations across an entire system and the number of people who are being touched. And how do we do that? How do we give guidance so that people are making decisions for the right reasons and getting the patient to the best possible destination? You were going to say something, Jeff, before I interrupted.
I was going to say something that honestly I've learned from you, from Mike Tegman, and from Scott Bourne, and that is that you have to separate out how you're measuring performance and what you do with those results. Completely different concepts. So I am black and white about if we're going to intubate, it will only be after we have demonstrated we can do this safely because it's a patient safety measure. That isn't removing clinical judgment. The clinical judgment is picking the right patient and identifying that, and that is 100% a clinical judgment thing. But the other issue is what happens if you didn't. Who knows what happens? You didn't do this. I'm not going to shoot you. I don't shoot people. It is what you
Despite
do
the fact
with
that
the
you're from
information.
Texas.
No, I shoot critters, not people. So, are armed to the teeth, because if you're not armed when you move here, we will arm you. It will. Here's your gun. Come on.
Don't tell Shane you can leave me for Texas.
Yeah.
Upstate New York is not exactly without their guns. I have been there. We have more in common than
He
you
has
might
tried
think.
to get me to go shooting with him multiple times. I have not gone yet, but
We're getting
I don't know
close.
why
So
Shane wants me to have a weapon in his presence. But
It's a valid point.
we'll explore those feelings at another time.
that distinction, Scott Bourne really, Scott has this wonderful way of, Scott has been a mentor of mine for decades, and he has this wonderful way of calling you on your bullshit without being mean about it. And the one he got me on most recently, it was in Oregon last year. And it was about the someone has to pay. You're a medical director and people are not following the hill that you're going to die on. And you're like, but they have to pay, right? Whether it's you got to do more training or you got to do something. And he's like, but what's the end result? Why did they do this? Do you think it is a lack of knowledge? If you don't think it's a lack of knowledge, how is that training that you're making them do going to impact the likelihood that they do it again? Are they going to do, how likely do you think it is that they're going to do it again after you have talked to them on all those things? Like, yeah, but, and then it dawned on me what was about to come out of my mouth after but. Someone has to pay. And I'm like, damn it, you're right. I am doing that. I need to stop doing that. Yeah, the measure is one thing. The policy is another. What you do with people who don't follow policy is a whole different issue. And that's probably not where you're really trying to go with this discussion. But it's very important.
But I think it's important because it's the curiosity as to why and what were the barriers. So we're going to talk.
It also informs your next Darby diagram.
It does, right? So there was two measures that we worked on as a region as part of the Airway Collaborative. One was Airway 18, which for everybody is using capnography to confirm invasive airways, not just intubations, but supraglottic airways. That was mostly driven by the evidence that was developed by Vithalani and crew that was discussed by Jeff earlier. And when we talk about this, if you ask a medical director and says, what's your expectation for the percentage of invasive airways that are confirmed with capnography? Most of the time when you ask me about what's your expected percentage on a quality measure, it's not 100%, right? Because one time at band camp happens a lot for other measures, but this is the one that I think most of us feel pretty strong as 100%. And actually since learning, when we talk about implementing it, we've had a few cases which had capnography but weren't exactly in the right place, and we're learning a lot about what does it what should this optimally be, and we'll explore that kind of another time. But I've learned that this is not as infallible a measure as I think I would like it to be, because I want a measure that is completely infallible for safety.
Wrong field for you, Maya. So I think you're talking about a measure failure. A measure can fail in multiple ways, right? So
I'm talking about a measure failure. Like they put a tube in, and there wasn't capno initially, and then capno came, and it was at 9, but it was actually just an ET tube working as a supraglottic airway. Is probably what happened.
So,
right?
and this, when you have that, it is probably the definition. What's your definition of waveform capnography, and why you can't just look at the box was checked on the EPCR? You have to look at the waveform. So, if you have an endotracheal tube,
those can have a waveform of
it's a little turtle, right?
It's So there's a lot of information there, but I think when we said how do we get everybody to do this, And when we entered the Airway Collaborative, the way that we built our driver diagrams, and driver diagrams, for those who don't know, are tools to develop ideas for what we're going to change. This led to one of the most insightful comments in my career, and it was by a paramedic named Emily Allen, who said, the thing I don't understand about when we talk about waveform capnography is people keep talking about it, that it's a gold standard. It is not a gold standard. It is a minimum standard, because if I don't have it, the tube should come out. And that's a minimum standard. That's not something I aspire to. That's something that I must have. And so I was like, she said that, and it was this moment of somebody like looking into the way that we speak about things. And so we actually wrote a policy, and we learned like some people like needed a policy called minimum standards for invasive airway confirmation, and defined it as a minimum, not a gold standard. It was a minimum. And I've learned more that it is the minimum standard. The minute, right? Like it's a minimum standard. And that became a regional policy that defined this as a minimum standard for both supraglottics as well as invasive airways, and talked about the evidence. So I want to ask like Shane, right? Because you were part of that kind of whole movement. We passed this, and we were at 95% confirmation. We have been for over a year at 98%. We still have a fallout here and there. And when we have a fallout, there's curiosity as to why the fallout happened, right? And sometimes we identified like moderate issues, etc. But I want to understand your perspective first, like as part of the quality process, and then maybe discuss the case where you're like, Maya's going to want me to pull this tube.
Yeah.
Remember your human popsicle?
Yeah. So I think it's it was a refreshing standard in the case that there are certainly people who would put a tube in and be like, I'm really sure this tube's in, I'm going to leave this tube in. And it's nice to create like this set in stone rule that if you don't have that, then you just need to pull it. There's like no questioning. Let's put the laryngoscope back in. Let me take a look. Like if that does not exist, then you just need to pull the tube. And I think that actually created it and made it a little more reassuring for people to say, because every time somebody would do that, they'd be a little bit nervous. Like, oh, maybe you take a look. And then, you're 5 minutes down the line and you've had an esophageal intubation that 7 people have taken a look at. The case that I had was a cardiac arrest roadside. It was somewhat hard to delineate how long this guy had been truly outside, but the weather was between like 10 degrees outside, so he was quite cold.
Not Texas weather.
Yes, it was not.
Well, there was that one time in February.
There was the one time where Hoffman fell apart. Yes.
We had video laryngoscopy. It was non-recording at that point. I intubated, no problems, and the waveform capnography popped up. It was like 5, 3, 3, 2. I was like, well, that's a problem. There must have been something wrong. So I ended up pulling the tube. We reventilated. I had somebody over my shoulder, put the laryngoscope back in. I'm like, here's what I saw. He's like, yep, that's 100% the airway. Perfect. Put the tube back in. And the exact same thing happened. So I ended up pulling out the tube. And the person who was with me is like, what are you doing? Like, this is very clearly in. It's like, this is not the standard that we have, though. And I can't stand up in front of a group of people and say, if you have an end tidal less than 5, you need to pull the tube. Except this one time I didn't follow my own, the only rule that we have created. So at that point, that is the standard needs to be followed.
And I think the discussion there is amongst the medical directors, we had a discussion like, should we allow like 2-person confirmation? Should we allow these things? And I'm like, no, because I think about the potential harms. Shane guy was dead. Like he was like supremely dead. And so in the end, right, that ET tube was not saving that patient's life. Like we did not withdraw a life-sustaining intervention or life-regaining intervention for that patient. If it was esophageal in that case, right, and we permit that tube to stay in, that we guarantee that no life-sustaining treatments are going to happen for that patient. And I think like if we allow a slippery slope as a system, I can't really think of the patient where there is no capno, right? Who's going to be saved by the ET tube.
Yeah, fair.
Right?
So,
like maybe even the supermassive PE is not being saved by the ET tube. Like I tried to think of these circumstances, like who is this mystical patient saved by an endotracheal tube where a capno is less than 5 for 5 breaths if the tube is in the right place? And I like searched for them in the recesses of my mind, and I could not find this magical patient. And then I thought, who is the patient who we're going to convince ourselves this tube's okay and be hurt by them? And I can think of that patient easily. I can think of
Well,
multiple patients in multiple circumstances.
his name is Drew.
His name is Drew. Yep.
So there's a reason everybody knows who Drew is. There's a whole campaign about this, Do It for Drew. We straight up assassinated this poor kid named Drew because we were so confident the tube was in the right place. Zero capnography. So I think there are a couple of things that are worth discussing here. And we have this conversation among my other medical directors. In our system, the physician does all of the cardiac arrest terminations. So we'll get calls about patients that don't have end-tidal CO2, and we're trying to determine why. There are two very distinct cases. One case is that you intubate or put a supraglottic in. You get waveform CO2, and it very rapidly, over about a minute and a half, goes away. Four-phase waveform getting smaller and smaller and smaller, and then goes away. I have seen that behavior personally when I intubate cadavers. Their legs are gone. They are dead. Trust me on this. I pulled them out of the freezer. They're stiff. Intubate them, waveform CO2. It just doesn't last very long. So there are two things. You never got waveform CO2, and you had it and lost it. And Shane, it sounds like the person sickle you're describing, you had it and lost it. And, oh, by the way, the other clinical characteristics are consistent with that, because I can't imagine that patient had a narrow complex rhythm at a rate of 80. The dude was in a systole, I'm assuming.
Yes.
But
And
I think
probably under room temperature.
But I think the sustain, right, that has to be sustained for greater than 5 breaths.
Yeah.
You know, we review videos, and I've seen video, and I was like, that is an esophageal intubation. And there was a capno of greater than 20 for about 5 breaths, but then it went away. And I look at that, and it's because some people drink a Diet Coke before they die. You know?
Yeah, and that's where I wanted to go back about failure
Yeah.
of a measure. It can fail because it's like a type 1 and type 2 error, right? You can do the thing and it not pick up.
Mhm.
So like I intubated and I failed because I never got waveform capnography. Okay, well, the measure's working. You can say, I did it. There was waveform capnography, but it didn't end up in the chart, whatever the issue is. That would be a failure, even though they did the right thing. And then there is I put the tube in, I met the measure, I had the 4 phases, and there was still another problem. That last one is this measure can't get to. And
No.
it's just a limitation of the measure.
But I think that's why even like more evidence that it's a minimum standard. But I
Yeah,
think
I like that. Props to Emily. She really baked my noodle on that. I've not thought about
it's
that.
on. Like we haven't written the paper yet, and I think eventually we will, along with the case series of the things that might kind of break our reliance and even argue that it's a minimum. But it was.
Can I go back to one other thing,
yeah,
Emily?
absolutely.
I have Emily on my brain. Maya, is the thought process that you verbalize talking about Shane's case. And I started off life as a programmer, so I have a tendency to think in branching chains. And I think one of the hearts of clinical decision making is to break it down into, well, what are the 2 choices I have? What are the 2 branch points? And what are the consequences of being wrong on each of those? So you have a patient in cardiac arrest. You have an airway that you think is in, but you don't have waveform capnography. Okay, well, there are really only 2 things you can do. You can leave it in or you can take it out. What's the downside to leaving it in? Well, it's esophageal intubation and you've guaranteed that they remain dead. What's the other alternative? I pull it and then do something else. Well, what's the downside to that? Well, I might remove a perfectly good airway and then not to be able to secure the airway at all. Okay, what would not being able to secure the airway look like? Where you are right now. So when you think about that, it's like, okay, well, door A, that's not viable. Door B may not get you where you want to go, but that's really the only choice you have. And I think if you try to break problems down like that, and I do this in real time with practice, and I think this is the heart of clinical decision making, is that you get to the point where you have adopted heuristics where That's really what you're doing in real time, is breaking down what your options are and looking at the consequences of each of them and then driving your behavior that way. So I love that example. I just wanted to really dig into that.
The same thing happens as a medical director in a system or somebody who's doing system quality improvement, as I try and think about how do we set a standard that has the maximum amount of benefit for the maximum number of patients within our system. And I think very often people think about like this one patient they had one time, but that's not reflective of like the overall system. And I think that's the goal of clinical policy and quality improvement, is to like design systems to have the maximum amount of benefit for the maximum number of patients in the maximum number of circumstances. Which takes us to the other policy that I didn't expect to write, but it came out of like looking at a system, and it was a hard policy to phrase. And it ended up being called invasive airway in patients with a pulse, which meant like the non-dead. And
Not undead, but non-dead.
not the non-dead, not like the not dead yet. And part of this came from, it's a little bit of our system design. So here, we're in a region in upstate New York. There's 17 regions in New York. In Monroe, Livingston, drug-assisted airway management is a regional level credential. And I will, like, the hill I will die on is a rigorous credentialing process for people. You're giving tools that they now can kill people that they did not have before. Like, I feel like that's my hill that I will die on. I feel really strongly about that. But
Preach, sister.
the circumstances that creates is that not every paramedic can do drug-assisted airway management. It does concentrate those skills also like in fewer folks. But so there has been, right, in EMS a long time, actually. Mike Perlmutter and colleagues out of Minnesota just published a paper on RSA, which I think the most interesting conclusion from their paper was not the growth of RSA, but actually the number of patients who were not dead, because they specifically looked at not cardiac arrest patients who had no medications whatsoever and a tube shoved in. And when I looked at our system, like that's to me the most interesting and troubling conclusion. When I looked at our system, now that I was seeing all these different airways, right, from both circumstances, because I was tracking all the ones where we use drugs and I was tracking all the ones where we use patients, I started saying, like, are we doing that in our system? And we were, and not out of maliciousness, but because people are taught GCS less than 8, like you can intubate, or if this person's unresponsive enough, you can shove the tube in. We weren't doing it often. We were doing it like 5 times a year across our system. But when I was like, that's 5 times a year too much. So I want to talk a little bit. For me, the drivers here is that, one, I've seen bad outcomes, seen people who were not as unresponsive as you thought they were, and right? Like, and bad things happen. But also, to me, it's kind of the way that things are done, and that we have other tools to manage these patients that are not routine, or Jeff's word, raw dog, but that seems a little too dirty, even for me. Intubation.
I feel like I have just met a life goal here. I have out Maya Maya.
Yeah. I'm like, raw dog. I'm like, ooh, that makes me feel kind of dirty.
It's a little Texas flair. So it's interesting on this. Would you like some data? I did a paper, just released this in Annals, looking at the association between intubation first pass success, not in cardiac arrest, so in patients with a pulse, and the way that they got drugs. So 30% of patients got an intubation without any drugs at all. 51% had RSI, which I described as a paralytic and a sedative. 18% had a sedative only. And then, are you really ready to just stay awake all night? 1.3% had a paralytic only, no sedative. And by the way, first pass success is higher with RSI than it is with no drugs, and that it is with sedation only, and sedation only is no different than no drugs.
And for me, the thought process is, when you talk to medics about why did we do this, right?
Yeah.
The most common context, the thought process is one of good intent, which is, I'm having trouble oxygenating this patient, and so I think I need to escalate my airway approach. But if you think about that circumstance, I'm having trouble oxygenating this patient with a BVM. And so what I'm going to do is I'm going to instill apnea and keep them apneic while I screw around in their airway under the most difficult intubating circumstances possible, which is the patient who is like not dead and their cords are opening and closing as I'm trying to
And
pass
they're
a tube.
already hypoxic.
And they're already hypoxic, and
They
it's
are
like
already falling off of the DSAT curve.
it's a recipe for disaster. And I
Yeah.
think the thing I struggled with in like writing a policy, right, is how do you account for that patient where like my number one choice is that they call a clinician who we have credentialed who has additional skills to bring to that patient. But I also acknowledge that that's not a resource in every single circumstance that is going to be available when it's felt that that is needed. And so honestly, in some of these patients, I'm like, if a patient takes an OPA, like they can make a supraglottic airway, and usually failed BVM is due to an anatomic reason that SGAs and iGel will take care of.
That was very generous explanation there, Maya.
Yeah.
Let me just talk Texan to you. It's because we suck at BVM. I can teach insertion of a supraglottic. I have come to grips with the fact that I cannot teach my 2,800 clinicians how to effectively form a mask cell. So I don't try. Supraglottics is a BLS skill here in my system. And I just say, don't even muck with the BVM. Just go to a supraglottic.
Yeah,
It's
it's like the
just as
OPA. Like if
fast.
you're putting in an OPA, you might as well put in a supraglottic as long as you
Think
have
about it as a
that
great big
recipe.
OPA.
Yeah.
I don't think it was
And so that
the
was
sorry, my enemy to interrupt. I just don't think
yeah,
it,
no, go
and
ahead.
this was instilled in paramedic education for the longest time, right? Like if you have somebody who's hypoxic despite measures, then you should intubate them. And even most of the
Right.
protocol sets would say you should take an
But
escalating
the
approach to airway
protocol, the
management.
airway management protocol allows it in our state, right? Like allows it.
That used to be an indication for RSI within the region was the person should be hypoxic before you consider RSIing them. So it's such a switch in people's minds to say, not only is this, but you need to be the exact opposite and optimize these conditions. So it's not the paramedics' fault, certainly, because that's what they've been told to do for so long.
Including, I might add, by me. I mean, it is the profession moves on. That was what I was taught as a paramedic. It's what when I was a paramedic instructor, that's what I taught. And it's interesting. I went back to Nancy Caroline, the book that I learned with, and it actually says, yeah, you need to do pre-oxygenation. It was like half of one sentence about properly prepare the patient, and my little eyes went right over it, and nobody looked at it. But we've always said, get the oxygen saturation up. We just didn't emphasize it.
And I think we didn't create process by which it happened. If you think about the Area 1 measure percentage, like it's a documentation problem. Like, no, it's a process problem. It's completely a process problem because you haven't actually created a process that allows stopgaps on like what are the goals of each step of the flow. And so it's a process problem. It's kind of like, I mean, this is going to feel weird, but like I go to the grocery store and I come back and I've forgotten, right? Like I've forgotten the key things that I meant to buy, right? This always
But
happens.
it's not just me.
It is, but it's a process problem, right? Because if I wrote that down, if I wrote it down and I check things
Forcing
off
function.
and I check that I've gotten everything before I leave the store, I haven't actually changed anything about the process of going to the store and coming home, but I have changed the process to make sure that along the way, I've made sure that the things that needed to get done actually got done. And this applies to like so many different parts of our life, but I try and think from, when I think about clinical policies, the one thing we excluded, and I know like when I sent you this policy, Jeff, to read, there was an interchange was like, how do we deal with, like grandpa, where I'm like fishing some steak out of his airway with McGill's and cause like an RSI provider is not gonna be there, right? So like we created like that to me was a legitimate exception of like the upper airway obstruction and the unresponsive patient where I'm fishing stuff out with McGill's.
Yeah, I think maybe I didn't make myself clear about what my question was. I think my question was a grammar question, not a clinical
Yeah.
question. And you clarified, I think it was one of those, it turns out where you put a comma is important. And what was being modified, I read it as this thing, or this thing. And the last this thing was you can't oxygenate them. And I'm like,
Yeah.
well, no, that's what you're trying to get around. And that wasn't what you were saying. So yeah, it was a where's the comma issue.
It was a word of the comma. Yeah. So like,
Yeah.
I think you have to think about some of like, when there's the exception, when there's this like theoretical one time at band camp patient, is that really a theoretical? Am I going to put somebody in a situation where they're more afraid of the policy than something bad happening to the patient, which is never the intention of a clinical policy at all. And so that was an exception. I mean, I think the policy showed an evolution of like we can do better, like we have different tools. And the tool that we have taught you to solve a problem is not the right tool for that problem. We have other tools to do that.
You know,
But
the foreign body thing is interesting. The way I got around it is that is not an intubation attempt. It's a definitional thing. So we were talking about success. An intubation attempt is what happens between blade insertion and blade removal with the intent to intubate. So if what you have in your hand is McGill forceps and you go in, you're not going in to take a look, which is the usual bullshit answer for why you missed. No, you're going in to get grandpa's dentures or the steak or whatever it is that's obstructing the airway. That's not an intubation
yeah,
attempt.
sometimes, right? Like sometimes you can't get the piece of juicy orange on the side and you're going to put a bougie and a tube through the hole to secure an airway that you're protecting from the thing that's flopping in occasionally. And there's a great video from Casey Patrick and MCHD where they did something just like that. But yeah, I think both of these policies came out of looking at our data and practice and saying, how do we align the guidelines, which is really what clinical policy is, the guardrails to help people make decisions with something that is more patient-centered. And I think it's worthwhile explaining the reasoning behind that. There was lots of concerns that were legit. They're like, what about aspiration? And then you can talk about the data. And I've just like come to terms like aspiration happened before we got there in the majority of circumstances. Like, I think that there's pretty good data on a lot of these things where we like blame aspiration. And it's
The CAM trial is a great one. And the patients most at risk for aspiration, I think we might agree, are those that we BVM'd for a while and then we're pressing up and down on their chest, their abdomen, who knows where we're really pressing. So cardiac arrest increases the risk of aspiration. And the CAM trial in France compared BVM to endotracheal intubation, and there was no difference in aspiration risk. And then here was the fascinating thing. Of the patients that we thought were aspiration, there was no difference in aspiration pneumonitis or pneumonia or death. So I do think this is one we've overblown the risks of.
yeah, I think if I look back on the things that I was like super worried, I mean, there were so many things, if you look back, that I thought were truth that are not truth. Like think about intubation, think cricoid pressure. I mean, do you remember? It's like, you're like, stop,
Burp, baby, burp.
right? Things like if the airway's contaminated, you should use DL, right? Jim DeCanto taught us we were idiots around that.
I love that. Well, that's how there's no way you can possibly use VL when the airway is full of shit.
Yeah,
Don't intubate if the airway is full of shit. Get the shit out first.
yeah, exactly. And guess what? You can continuously suction. So I think that this is just along sort of this migration of people who are thinking and looking at data, but like when somebody says something like it is truth, you should question it. Not me when I say oxygenation and ventilation is important. I think you're going to be hard pressed to say that
No,
those
please
things
question me. When I say shit like that, question me. And I better be able to give you some data on it.
I give you the evidence, right? From things like the work that Dan Spate has done in TBI and the work on peri-intubation arrest. Like we should be able to defend it. And then when new evidence comes out, then we got to change what we do.
There's a great quote on that says it was by, I'm drawing a blank on, I want to say Milton, maybe. It was like an 18th century economist. and somebody was basically accusing him of flip-flopping. And he said, well, when the evidence changes, I change my opinion. What do you do when the evidence changes? When the evidence changes, I change my damn opinion.
So I think these clinical policies, right, are written on like stone tablets that will never change. And I think as
So you're saying there's still a chance I can intubate again?
yes, there's still a chance when the evidence changes. Or you take a time machine and go back 30 years. But
It's a good thing I was a paramedic when I was. We got to do all the fun stuff. Other than save patients.
Yes, other than save patients. I think it's this is the funnest part. So I want to give you an opportunity to have the last word, both Shane and Jeff, who usually know that it's difficult to get the last word in with me. But before I give you the last word, I just want to thank you very much for taking time out of your very busy schedule to talk with us about this. So,
well, I'll give Shane the last word here. I love the opportunity to talk to you every time. It's been a great conversation. Thank you very much for having me on. And I love the fact that you are very focused on putting the needs of our patient above our own psychological needs. I had a great mentor who was a paramedic instructor, Mark Yeager, years and years ago, and he said to every incoming paramedic class, congratulations, you have chosen to be a servant. Being a servant means you put the needs of your patients above your own. So thank you for being a servant.
This has just been a really fun project to be a part of, and it's cool to see how far the project has spread. I think when we started talking about airway management, I had this heavy focus on what was the RSI clinicians or DAM clinicians. And it's incredible going to calls and watching the BLS first response fire department say like, hey, your cabno sucks, you need to fix it. And seeing how like some of these lessons and things that we've learned along the way have really spread and not just benefited what is a small core group of patients that, you know, a small percentage of paramedics will physically touch, but those lessons can get passed further along to, you know, hundreds of people that can touch thousands of patients, not just within this region, but even further. So I think seeing the reach of it has probably been the most fun part. And I think keeps the project going, keeps everybody really excited to be part of it still.
That's a wrap on our first episode of the EMS Clinical Brief. Thanks so much to Jeff and Shane for joining us. We hope that you tune in next month when we discuss optimal pain management strategies for geriatric patients with suspected hip injuries in the field. Tune in then.